This is Dr. Gaber. Pancreas cancer is on the rise. It is the fourth leading cause of cancer, and it is a silent killer. And when it becomes symptomatic, it is usually advanced and incurable. According to the American Cancer Society, if you live in the United States, your risk of getting pancreas cancer is 1 in 62, and your risk of dying from pancreas cancer is 1 in 72. But some people do find it early and survive. The 5-year survival rate for very localized pancreas cancer is 37%. For pancreas cancer with regional lymph node metastasis, it is 12%. And for pancreas cancer that has metastasized, it is 3%. 65% of pancreas cancers are found in the head of the pancreas. 85% of pancreas cancers found are already surgically unresectable. The majority of pancreas cancers occur in patients over 60, which is the time to become more vigilant. However, if there is hereditary pancreas cancer in young family members, we start surveillance at 50 or 10 years younger than the age a relative developed pancreas cancer. So how can we detect it early? The pancreas sits behind the stomach and secretes insulin and pancreatic digestive juices. 75% of pancreas cancer patients complain of abdominal pain. Any persistent upper abdominal pain or left mid-back pain may be pancreas cancer. It may be a dull aching or severe persistent pain, somewhat relieved by leaning forward. Especially if the pain is proven to be not from gallstones, and the pain goes straight through to the back, and it is not relieved by PPI drugs like Prilosec. The pain may be pancreas cancer or just pancreatitis. Bloating, gas, foul-smelling, or yellow oily stools can be sign of poor output of digestive enzymes from pancreas insufficiency accompanied by pancreas cancer. Fatigue, weakness, and malaise are common, and weight loss occurs in 9 out of 10 patients. Obstructive jaundice may cause itching. Vein thrombosis in an arm or leg can be a presenting feature of pancreas cancer. There are other clues to pancreas cancer. We get suspicious of pancreas cancer if there's a history of smoking, alcohol abuse, exposure to petroleum products, or naphthylamine, obesity, diabetes, hepatitis B or C, Helicobacter gastritis, cystic fibrosis, pancreas cystic disease, infestation with the Chinese liver fluke, hereditary pancreatitis or recurrent pancreatitis, or, as mentioned, a family history of pancreas cancer, or a personal or family history of melanoma. BRCA1 or 2 gene, breast or ovarian cancer, Peutz-Jeghers syndrome genes, and the hereditary colon cancer syndrome genes make you suspicious. 15% of pancreas cancers are hereditary, and gene testing is now inexpensive and available in most internal medicine offices. Also, if a patient over 50 develops diabetes or borderline diabetes, they may have pancreas cancer, and a yearly A1C to detect diabetes is a good idea. Another clue in men, if the testosterone to dihydrotestosterone ratio is less than 5, he may have pancreas cancer. I order this test now yearly unless the patient is on Proscar. If the liver function tests show an elevated direct bilirubin, gamma GT, or alkaline phosphatase, we are suspicious of a head of the pancreas cancer blockage of the common bile duct. The CA19-9 blood test usually cannot find early pancreas cancer and is obtained if the lesion is noted. Treatment: a Whipple's procedure pancreaticoduodectomy is the procedure of choice for resectable pancreas cancers. Adjuvant chemotherapy and external beam radiation is usually given. Gastric and biliary bypass operations are done for unresectable tumors. A celiac nerve block can control the pain. Pancreatic enzymes can be given for pancreatic insufficiency. For detection, abdominal ultrasound and CT scans of the abdomen often miss early small pancreas cancers. CT should be a multi-phase or pancreas protocol CT with IV contrast. Endoscopic ultrasound, EUS, with ultrasound probe in the stomach can often find pancreas cancer, and an MRI or MRCP of the pancreas can find it. If only an MRCP is done, it just looks at the pancreas ducts and does not require gadolinium contrast. ERCP can find it, but is not without side effects, as dye injected into the pancreatic ducts can cause severe pancreatitis. Pancreatic juice collected when the ERCP is done can be sent for gene mutation studies. Suspicious lesions are biopsied with the US, and fluid collected from cysts can also be sent for gene mutation studies. If hereditary predisposition to pancreas cancer is found or suspicious lesions are seen in the pancreas, alternating MRCP MRI with EUS yearly is advised. Benign pancreatic cysts are not uncommon but must be watched closely for enlargement. Lipase levels are usually normal. If there's a history of weight loss with lack of appetite, we must look for hidden cancers of all types. We also look for sudden unexplained drops in cholesterol, which can be an indication of a hidden cancer of any type. If pancreas cancer is at the head of the pancreas, bile duct obstruction is not uncommon, and painless jaundice may be noted alone with Courvoisier sign, which is when the physician can feel a markedly distended, non-tender gallbladder. Pancreas cancer in the tail of the pancreas can cause splenic vein occlusion and subsequent gastric and esophageal varices with GI bleeding. I hope this discussion has been helpful.